Hi everyone, welcome back to Torrey's Top 10. We'll be looking at the top 5 things that you should know about Chapter 5 on informed consent. Number 5, what is informed consent? Informed consent goes beyond what we looked at in the last chapter in terms of truth-telling and confidentiality. So, what is informed consent? Informed consent is an informed person's autonomous agreement to submit to a medical treatment or research experiment. Informed consent is both an ethical ideal and a legal obligation. Physicians have to inform competent persons about their treatment so that the patient can choose whether to agree to the proposed treatment or not. Or, as we'll see in the next chapter, informing research subjects so that the research subjects can make a decision about whether to participate in a research trial. So again, in thinking through issues of informed consent, we see a conflict between the two moral standards of autonomy and beneficence. And our concern, again, with informed consent is with issues of paternalism. We know that autonomy requires that we respect competent and rational people's capacities to make decisions for their lives, to be self-determining individuals. And we know that beneficence requires physicians to do what's in the best interest of their patients. So it could be argued that informed consent promotes patient well-being, since respecting autonomy is consistent with promoting or upholding the standard of beneficence. That respecting autonomy is, in fact, doing good for one's patient. The number 4 thing you should know about informed consent is what are the conditions for meeting informed consent? The conditions for meeting informed consent are, first, that the patient is competent. Second, that adequate information is disclosed to the patient. Third, that the patient understands the information. Fourth, that the patient decides freely. And finally, that the patient consents to the treatment. So each of these criteria are conditions of meeting informed consent. If one of these is not met, then informed consent is not met. Let's look at each of these in turn. Competency. The patient must be competent. But what does it mean for a patient to be competent? As your text states, competency is the ability to render decisions about medical interventions. Now, this doesn't mean that the competency criteria is easy to apply in all cases. There are some clear cases of incompetency, but there are also less clear cases. And incompetence can apply to one particular aspect of a situation. It doesn't mean that a person is completely and totally in every way incompetent. Some clear cases of incompetency might be mental incompetency, cognitive incompetency, alcoholism, addiction, mental illnesses related to age, like Alzheimer's or dementia, psychosis. Some examples of less clear cases of incompetency: the inability to understand the reasons for a decision, the inability to communicate a decision, the inability to understand the implications or the possible consequences of a decision. So these may not be global incompetence, but they may be enough to show that a person is not capable of making a competent decision about their medical care. What is adequate disclosure? How do we know when a physician meets the criteria of adequately disclosing information? How do we know how much information is sufficient and which information is sufficient? Adequate disclosure requires that a physician give enough information to allow patients to weigh their options. A physician-based standard ignores the patient's need for information relevant to their decision, whereas a patient-based standard assumes that patients know what information they need. So we have 2 different approaches to disclosure here. One where the physician is at the center deciding what information is relevant, and one where the patient is put at the center and the physician assumes that the patient knows what information they need. Legally, Physicians are required to disclose the following information. First, the nature of the procedure. What will the procedure be like? How will it go? What is involved in the procedure? Second, the risks of the procedure. However minimal, what known risks are there for the proposed procedure? Third, a physician must disclose alternative options. Even if they don't recommend those options, they should at least propose some alternative options. And fourth, they should disclose the expected benefits of the procedure. What can the patient expect as a result of having the procedure or treatment? Now, there are some exceptions to the second criteria that include things like emergencies, when there's not time to disclose, waivers, or therapeutic privilege, which is a contentious issue, but with therapeutic privilege, a physician has the option to decide paternalistically that it's in the patient's best interest if they don't disclose something. We saw in the Canterbury case that adequate disclosure should be seen from a patient-based approach. The Canterbury case ruled the following: true consent to what happens to oneself is the informed exercise of a choice. So to evaluate knowledgeably, the patient's right of self-decision shapes the boundaries of the duty to reveal, which is measured by the patient's need. So this puts the patient at the center of adequate disclosure and informed consent. As we mentioned, therapeutic privilege is a physician's privilege to withhold information if they believe that disclosure is likely to do harm. The amount of leeway that physicians have varies both legally and institutionally. And of course, this is an open question morally. The third criteria of patient understanding requires that patients are able to process the most relevant information and appreciate the consequences of their choices. There are many things that affect a patient's ability to understand, not merely their cognitive, mental, or emotional health, but also things like the timing of the information and the informed consent, fear, denial, disillusionment, and so on. The fourth criteria, that a patient has to freely choose, requires that physicians do not coerce or manipulate a patient into a decision. Physicians should influence patient decisions as authoritative knowledge sources. That's why we go to physicians. That's why we go to doctors and hospitals and seek medical care, because doctors know more than we do about our situation. But the patient should still be making the choice freely once the information has been disclosed to the patient. So physicians should influence patient decisions, but they shouldn't do so in a coercive or manipulative way. And the fifth criteria of patient consent goes even further than the fourth criteria of freely choosing, and it requires that consent is more than assent, so the patient has to assume responsibility for the choice. Ideally, the patient signs an informed consent form and formally recognizes responsibility for choosing, although in practice this often doesn't happen. The important thing here is that the patient doesn't just agree or assent to what the physician says, but that they take responsibility and say, yes, this is what I want. I affirm that this is my decision and I take responsibility for this decision. So consent goes beyond just merely assenting, going along with a physician's recommendation. Number 3, how have legal precedents influenced moral arguments on how physicians should disclose information to patients? We touched on this a bit, mentioning the Canterbury case, but let's look at a few of the influential cases that have influenced how we understand, both legally and morally, what informed consent should be in practice, ideally. The Schlendorf v. Society of New York Hospital case ruled that every human being of adult years and sound mind, every competent adult, has a right to determine what should be done with his own body. So this is a ruling that clearly rejects paternalism in case of informed consent. In the Salgo v. Leland Stanford Junior University Board of Trustees case, the judge ruled that a physician violates his duty to his patient if he withholds any facts that are necessary to form the basis of an intelligent consent. So this puts a lot of pressure on a physician to convey all of the relevant information to a patient. And again, the Canterbury v. Spence case sets a legal precedent by arguing that the scope of the physician's communication to the patient must be measured by the patient's need, and that need is the information material to the decision. So really reinforcing this idea of a patient-based approach to informed consent. Number 2, what are some criticisms of the current practice of informed consent? The major criticism about the current practice of informed consent is that there are discrepancies between the ideal of implementing informed consent and how we actually do it in practice. So laws and policies often mandate only minimal information, like risks and benefits, to the patient. Moreover, physicians often view informed consent as a kind of red tape. And this reveals that paternalism as an attitude, as an approach to patient care, is still alive and well in medical practice despite the legal precedents and despite moral arguments. Physicians should see informed consent as a practice, as a means of promoting patient well-being and respecting autonomy, rather than seeing it as red tape or bureaucracy. And the number one thing you need to know about informed consent is how the major theories would handle the issue of informed consent generally. So it should be clear by now that an act utilitarian would look at issues of informed consent on a case-by-case basis. They would do a cost-benefit analysis, looking at the likely benefits, looking at the likely risks, and choosing the best course of action. So an act utilitarian would ask whether the benefits of complying with informed consent outweigh the possible harms of paternalistically not fulfilling informed consent. A rule utilitarian would ask what the consistent rule is that would produce the best consequences for everyone involved over time. If informed consent, as a rule, would produce the greatest good for the greatest number overall, then this rule should be followed. Although for a rule utilitarian, there may of course be exceptions to this rule. A Kantian is going to say that therapeutic privilege is never permissible because you would be failing to respect the patient's autonomy. However, it would be permissible for a patient to waive their right to informed consent. All right. Woo, we made it. These are the top things you should understand from the introduction to the chapter on informed consent. Frank, please stop licking things. Would look at issues informed consent. Would look at informed consent. No, go lay down. Go lay down. Woo, 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 woo. Ba-dum-bump.